This podcast is recorded in the land of the Kaurna people here in Adelaide. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members and trainees live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as Te Tiriti o Waitangi partners.
It's my pleasure to welcome Ranee Thakar to the podium. Ranee became president of RANZCOG in December 2022, and she's a consultant obstetrician and urogynaecologist at Croydon University Hospital and an honorary senior lecturer at St George's University of London. And she's been recognised by a number of awards for her leadership on a number of societies and organisations. Thank you, Ranee.
Thank you very much for that kind introduction. Thank you so much for asking me to talk about a subject I'm so passionate about. So today I'm going to explore how pelvic floor health connects directly to reproductive rights and why disparities in access needs our collective action. Because when we talk about reproductive rights, we think about contraception, we think about safe maternity care, we think about fertility access. But rarely do we think about pelvic floor health as a reproductive right. Yet, this too is about dignity, autonomy, and justice. I have no conflicts of interest. However, I do believe that pelvic floor health is not a privilege. It's not a luxury. It is a right. And over the next 20 minutes, that's what I hope I can convince you to believe in as well. So pelvic floor health is fundamental to a woman's life. It affects her quality of life. It affects how she works, where she works, how she loves, how she feels about herself. And yet, for decades, it has been left out of basic reproductive discussions. It has been left out of those major discussions that take place at high levels like UNFPA and WHO. It is seen as something women just have to live with, as inevitable after childbirth. This attitude reflects not biology, but inequalities. And the rights-focused lens reminds us that every woman has a right to live free of suffering from pelvic floor dysfunction. Because pelvic floor dysfunction is not rare. It affects 1 in 3 women globally. And yet, it is underreported, underdiagnosed, and undertreated. As I said earlier, 1 in 3 women are affected by pelvic floor dysfunction, be it urinary incontinence, anal incontinence, or prolapse. Who are affected by it? Well, there is a higher prevalence in low and middle income countries. We know that. And this is compounded by obstetric injury. It is compounded by lack of staff. But these disparities also exist in high-income countries. In the country where I live, in UK, we have a shortage of physiotherapists, for example. Women tend to suffer from an impaired quality of life globally. But you can actually compare it to conditions such as diabetes, such as arthritis. And yet, if 1 in 3 women suffered from any of these conditions, it would be a global catastrophe. And certainly, if 1 in 3 men suffered from this condition, it would be a huge issue. Yet, for pelvic floor dysfunction, there is lack of investment And if there's lack of investment, we do not know what the data is. And subsequently, this lacks visibility. And even if you think about postpartum care, we know that even in this area, there is underfunding and lack of prioritization. So, who are the women who get left behind? But disparities exist depending upon where you come from, the skin you wear, and your socioeconomic status. For example, we know that women in rural areas are more likely to suffer pelvic floor dysfunction. But in addition to that, we also know that they are very less likely to find trained providers. But these inequities also exist in well resourced countries. We also know that women in low and middle income countries have difficulty accessing care, surgical treatment, and good trained facilities. There are also cultural barriers. We know there are many cultures where this is a cultural taboo, absolute taboo. And there are inequalities, what we've been talking about. And studies from the UK and US have demonstrated that women from ethnic minority groups are less likely to receive the care that they deserve and more likely to have their symptoms dismissed. These gaps really reveal a deeper issue. And what is that issue? It's about how society values women's care and what aspect of women's health gets prioritized. Pelvic floor dysfunction can have a profound effect on a woman's confidence. There are multiple levels. What is the problem there? It starts at patient level, it then proceeds on to health systems, and last but not least, there are economical impacts as well. It has a profound effect on a woman's confidence, on the way she lives. But still, there's stigma, there are cultural taboos as well. We also know that there's lack of awareness and there is normalization of this whole situation. Women do not know where to actually seek care for this. And it is normalized, just considered that this is what women really need to live with. There are knowledge gaps about treatment. They do not know, even if they have symptoms, that there is treatment available for this condition. And when they do know, they do not know where to seek help. And last but not least, there's fear and misinformation. And with the whole issue that we have had around the mesh situation, we are seeing this more and more. Women are not coming forward to ask for help, but more importantly, they're frightened to ask for help. And when they do seek help, there are barriers in the healthcare system. For example, there's a lack of provider knowledge, even at basics in primary care. And what that means is that then the symptoms are not picked up and there is lack of really referrals for the most basic symptom. Women go around lost in system. There are fragmented systems out there in our healthcare services, going from one physician to the other, from a physiotherapist to a surgeon, to a urogynaecologist. There's lack of proactive screening. Basically, even when you go for your routine annual check or for your antenatal or postnatal care. What if we could pick up those symptoms early, start treatment, and prevent long term suffering? And last but not least, there are racial and ethnic inequalities. We know that women who are from minoritized groups, those difficult to reach, or I would say often ignored groups, actually do not find that they're getting care, they're often dismissed. But as we spoke about earlier, do we really think about how we provide these women with culturally sensitive care? And as if that is not enough, we also know that there are economical issues as well. It's about how we find insurance companies providing care. This is expensive care. We also know that there is problem with access to specialists such as urogynecologists. There are disparities in many rural areas. Women have to travel long distances to find care. And also, we know that women, in addition to this, have problems with time and competing priorities. If you have to go to multiple physiotherapy sessions, often women cannot afford it, they do not have the time because they have more caring issues that they need to deal with at home. But what we need is an integrated, affordable, and a structure that takes into consideration the life cycle of a woman. But there are green spouts of success, and we are seeing this there. We know that, for example, FIGO, IUGA, and RCOG have various policy statements. We have lots of training out there, and one of the documents out from the FIGO actually frames this with a view on human rights. In the RCOG, we have a policy document which defines the problem. This is based on interviews that we have done with women. It defines the problem. We use this to actually influence our politicians and stakeholders to provide care, to actually improve access to care for women. And more recently, IUGA has come up with a white paper highlighting how urinary incontinence, pelvic floor dysfunction is part of maternal morbidity. It's part of maternal care. And unless we frame it as a human right, we are not going to get access to funding, we are not going to get access to providing good care to women that we look after. We also know that there are very good models out there looking at community access to care in Chile and Ethiopia, for example, looking at how we provide care in the community, low resource by people who actually the patients actually trust, or the women actually trust. For example, this is something that Stephanie covered earlier on. And this doesn't need to be very expensive, but women actually trust you when you're providing them care about their incontinence of pelvic floor, because very often they do not want to talk about it. I too have problems. I don't have glasses, so I can't really see this over there. What about multidisciplinary pelvic floor clinics? These are mushrooming everywhere. A good model, because pelvic floor dysfunction affects every compartment, anterior, middle, posterior. Women can often have urinary incontinence, anal incontinence, and prolapse. So, how about colorectal surgeons, urogynecologists, psychosexual counselors working together to provide care? And that's the basis of pelvic floor clinics. We know that there are lots of new digital innovations. For example, in the UK, we have the Squeezy app, which is being used quite extensively to provide pelvic floor physiotherapy. And this is really important because we have a huge dearth, a huge lack of physiotherapists providing first line treatment. This is high impact treatment that can be provided to women. However, there is a huge shortage. But one thing I've learned as a president, that if you want to make change, we need to influence the politicians. So this is some of the work that we have done in the UK, and more recently, incontinence was actually debated in Parliament. And this highlighted the lack of staffing that we have, the lack of physiotherapists, the lack of urogynecologists, the lack of urologists on this subject. And once we get them talking, we can start making a difference. Theo Clark in the picture over here is a politician. She was from the Tory government, so our previous government, and she sustained a third-degree tear. She then talks about this quite openly and actually has written a book on this, and now is doing podcasts. And she spoke about it in Parliament, highlighting the issues that she has had after third-degree tear. Now, this is an area that I've been working on for over 22 years. But what she could achieve in about 6 months or 9 months after giving birth was much more than I could do in 22 years. So I work along with her. We have to find ways of improving access. And if I have to do that, I'll do that. She has had an all-party parliamentary group wherein we discussed pelvic floor dysfunction. She came up with a document. Unfortunately, just as we came up with this document highlighting lack of access and solutions to it, the government changed. So it's not getting quite as much traction as we would like to. And in the UK, we have a charity known as MASIC, which is a charity for women who have had obstetric anal sphincter injury. And I'm a trustee on this group. And this group essentially has got lottery funding, and we have sessions within the community to bring those women to come to talk about their problems. And clinicians are involved in this, but also it's about co-designing along with women who have sustained injuries. But what are the strategies? Well, the most important thing is that we need to normalize and destigmatize. How do we do this? Well, we launch public health campaigns. We bring this subject whenever we are talking about this, be it in the media, be it in those community projects that we are doing. We need to improve education and awareness, implement the life course approach, starting education right from schools into primary care, antenatally and postnatally. And we do this, we need to do it in a way that women understand. It may be through apps, it may be through multiple languages. Again, co-designing, trying to understand what women want, what's the best way to provide them with information. We need to improve provider training and screening. And if I had anything to do with it, I'd make pelvic floor dysfunction training part of mandatory training for nurses, doctors, and midwives. Because imagine the number of patients you can pick up during those consultations, during the antenatal period, and prevent disease from getting worse, preventing suffering in the long term. We need to look at how we promote first-line treatments. Often people believe or come asking for surgery, but there's low cost, high impact pelvic floor dysfunction. So let's try and promote that. We need to address disparities. Look at culturally sensitive interventions, be it in the community, be it education, be it interventions. And we need to advocate for systemic changes, how this is financed, how we have good pathways, and we all have a role in doing that. And last but not least, how do we promote research? How do we promote data collection? Because if you don't have data, you can't make a difference. But for everyone in the room here, I have one ask. You can all be advocates. Because guess what? We have the 3 E's. We can contribute with our expertise. You've all learned about pelvic floor dysfunction when you were medical students. If not, you can open a textbook and read about it. It's simple. It's not difficult. We can try and empower patients, those patients that you talk to in clinic, just by asking the simple question, do you leak? Don't be ashamed to ask them that. And last but not least, we can identify when there are inequalities because we see them. We see the woman in front of us who's avoiding talking about pelvic floor dysfunction, who's avoiding talking about anal incontinence or flatus incontinence. What we need is reframing this pelvic floor dysfunction as a human right, and this will change everything. It aligns with WHO's reproductive strategy and UN Sustainable Goals, Sustainable Goal 3 and 5. Because the right to health really is about how we provide good, accessible care. The right to dignity, free from symptoms, free from suffering, free from shame, and the right to non-discrimination. Living with dignity so that no woman is left behind with preventable suffering from pelvic floor dysfunction. And when we reframe pelvic floor dysfunction as a human right, we really can look at it as a matter of justice and not luxury. So my call to action is pelvic floor health is not optional. It is a matter of equity, dignity, and rights. And what we need to do is empower women with education. Look at how we build up capacity. We challenge stigma and normalize care. And last but not least, each one of you can be an advocate. So I end with where I started. Pelvic floor health is not a privilege, it is a right. Thank you very much for listening to me.